Good evening, all.
Good evening, sir. Sean, sir.
Good evening. Good evening.
Yeah, like please.
Good evening.
So, good evening, everyone.
Good evening, sir.
This gives me immense pleasure to welcome you all to this and yet another Wednesday webinar. And today's topic is Keratoconus Unmasked. So, as we know that the idea of this Wednesday webinar series is basically to have a clinical relevant topics which are in our everyday practice very close and we see regularly, and to make the learning more interactive. So we have deliberately designed this program not to merely as a series of lectures, but as an interactive clinical discussion. And today we have with us esteemed national faculty, Dr. Jagdish Reddy sir, who has been consultant and head of the Department of Cataract and Refractive Surgery Department at LV Prasad Eye Institute, Hyderabad. He has also served as an assistant professor at the University of Rochester for over 6 years, and he has a vast experience and is well known as an authority in the cornea and refractive surgery across the world. And we also have today with us Dr. Abhishek, who is yet another young budding cornea surgeon as a uh, faculty who will speak about the keratoconus diagnosis. And we will be having this session being moderated by our Dr. Neha Deshpande and Dr. Kavita Dangra madam. And we have esteemed list of panelists, Dr. Ajay Kulkarni sir, who is a senior cornea surgeon in Nagpur, and Dr. Pankaj Lande, Dr. Ankit Harwani, and Dr. Nikhil Kandurwar, who are all well experienced in the cornea and refractive surgery. And with this, before we start, I request our own President Dr. Sean, who has been always the guiding light for all our endeavors. So kindly uh, give your 2 words, Dr. Sean, sir. You are muted actually. आप म्यूट है सर. Please unmute yourself, sir.
शॉन सर, आप शायद कनेक्टेड ही नहीं है ऑडियो को.
Hello.
Yes.
Yes. Okay. Thank you, Rahul. Good evening, respected senior colleagues, dear friends, and young ophthalmologists. It gives me immense pleasure and pride to welcome you all to the 8th Vos Wednesday webinar as we continue this year a long celebration of 58 years of glorious years of Vidarbha Ophthalmic Society, the legacy vision 1976 to 26. 50 years is not merely a number, it's a represent 5 decades of knowledge, friendship, professional excellence, academic growth, and above all, our collective commitment towards the cases of ophthalmology. As we celebrate this golden journey, it is our endeavor at VOS to make the anniversary year not only a celebration of our past, but also platform to shape the future of ophthalmic friends and practices. And today, webinar is a perfect example for that vision, that is Keratoconus Unmasked. Keratoconus is a fascinating and challenging conditions with advance in corneal imaging, early diagnostic, biomechanical assessment, and newer treatment and modalities. The emphasis today are early detection, understanding the hidden cone, and looking at keratoconus from 360 degrees in extremely relevant to every practice in our ophthalmology. We are fortunate to have an excellent academic faculty with us. I warmly welcome Dr. C. Jagdish Reddy sir, who is taken us through a keratoconus 360 degree, a current concept and future detection, and our own VOS member, that is Abhishek, who is working in Karnataka, Davangere, and his topic is the hidden cone detecting keratoconus before it visible. So I'm sure both of these talks will give us a valuable insight that we can translate directly into our clinical practice. A special welcome to our moderator, Dr. Neha Deshpande ma'am and Dr. Kavita Dangra ma'am. Welcome. Who will steer today's academic discussions, as they always do. And we have a very distinguished panel for the interactive this discussion, that is Dr. Ajay Kulkarni sir, a renowned cornea surgeon, Dr. Pankaj Lande, a very academician and a YouTube blogger. All he is doing very well. Our own Dr. Ankit Harwani and Dr. Nikhil Kundiwar. I welcome you all. I'm sure this 30 minutes panel, and not more than that, like it is 60 minutes, sorry, discussion will make today's webinar even more practical, interactive, and enriching. I would like this knowledge and appreciate the efforts of our own VOS scientific committee. Our hero is really a hero, Dr. Rahul Tiwari, who working hard for this. Our co-chairman, Dr. Neha Deshpande, along with him, the committee members Naveen Soni, Rohini Juneja, and Nikhil Kundiwar. Their condition efforts are helping us maintain the academic throughout the year. As also taken the opportunity to thank our viewers, office bearers, my own friend, my brother, Dr. Sobodh Purohit, a scientific committee chairman, Dr. Rahul, treasurer, Dr. Shamik Ambedkar, and the entire viewers team and their constant support. And even thank you, Intod, for giving us this opportunity to have this one. So I declare to start with our session. Thank you.
Thank you for your encouragement, sir. And without wasting the further time, I'll forward to our moderators to conduct the program. We'll be having 30 to 40 minutes of first presentation, which is the expert-led talks, and then we will be having the questions which we have collected from all of our members. So over to you, Dr. Neha Madam and Dr. Kavita Dangra Madam.
So good evening, everyone, and I hope everyone is sitting in front of their, mobile or laptop with lot of, expectation from all the speakers as well as the good discussion. So I'll start with the introduction. Already the introduction majorly is done about Dr. Jagdish Reddy. He is, of course, he has done not only the fellowship and consultant in LV Prasad, but he has a vast experience of observership and seeing all the patterns of practice all over the world, including Wheelside Institute, or the Children's UPMC Children's Hospital, Petersburg, Netherlands Institute of Innovation Ocular Surgery, Netherlands, Rothschild Foundation, Paris. So extensive experience, extensive observerships, extensive, even he has more than 60 peer-reviewed publication, 3 full textbooks to his name. So I think without wasting much time, Dr. Reddy sir, please start with your presentation.
I think Neha Madam, I'll just interrupt you. Sorry. We will be having first Dr. Abhishek's talk because it's because about the detection of the keratoconus. And then sir's talk is basically management. Yeah.
Okay, so Dr. Kavita, would you like to introduce Abhishek sir?
Yes, thank you, Dr. Neha, and very good evening, everyone. We also have a very young and energetic, dynamic cornea and refractive surgeon. He has received gold medal probably thrice now, one in MS ophthalmology, and best presentations in his COSCON conferences in 2023 and 25. He has performed many corneal surgeries like penetrating and lamellar with corneal trauma surgeries. Probably the sky is just going to be limit for him. I welcome Dr. Abhishek GU, and we also request you to start your presentation on the hidden cone, detecting keratoconus before it's visible. Also, I would like to, we have already introduced our panelist, but yes, we have senior and respectable personality, Dr. Ajay Kulkarni sir. And as already been explained, a YouTuber who is sharing his knowledge with his surgical skills, of surgical videos, and a cornea consultant at Amravati, Dr. Pankaj Lande sir. And Dr. Neha, can you introduce both of them?
Yes, and Dr. Ankit Harwani, who is doing wonderful cornea practice at district level Amravati and doing DMEC, DSEC, everything. And of course, our own Dr. Nikhil Kandurwar, whose fingers not only play the piano, but also very nice. He does surgeries with his fingers. So I welcome you all and request Dr. Abhishek sir to start with his presentation.
Thank you so much for the wonderful introduction, ma'am. At the outset, I would like to thank Dr. Sean sir, Dr. Rahul sir, and the entire VOS. I started my journey of ophthalmology from Vidarbha itself, and for me to be participating in one of the webinars organized by VOS is a huge proud moment. So without further ado, let me start sharing my screen. Hope my presentation is visible to all, sir.
Yes.
Okay. So, ectasia of the cornea does not start once we diagnose keratoconus. A keratoconus becomes dangerous when we are not able to assess it or diagnose it much before it's visible on the topography scans. So, this are from my own experiences. Couple of patients who had undergone keratorefractive surgeries, laser-based vision correction elsewhere, and presented to me with post-LASIK ectasias. These were the scans of their pre-procedures. The topography scans do appear quite normal. However, they ended up having ectasia. Why so? Because the keratoconus or the weakness in the cornea was hidden in the topography maps. So, what actually is a hidden cone? It may be a formifaciate keratoconus or a subclinical keratoconus. Various literature have suggested their own definition of what each is. But to summarize all, a hidden cone is a one where there is structural ectatic changes in the cornea but were not visible on the routine topography scans. However, such corneas needs epithelial thinning mapping and detect any biomechanical abnormality in them. So how does keratoconus usually progress? The starting change appears in its biomechanical strength. There is weakening of the cornea biomechanically, which later translates into posterior stromal elevation. So the epithelium over the posterior stroma tends to thin to accommodate the elevation, and this is called a secondary remodeling of the epithelium. So that is what we see as epithelial thinning on the area of maximum stromal elevation on the epithelial map. It is months later that one can see visible changes on the topography scans. So what routine examination does is only detect keratoconus when it's too advanced. All the classical signs that are explained in the textbooks, like the Vaux striae, Fleischer's ring, appear only in advanced cases of keratoconus. A refraction, both uncorrected and corrected visual acuity drop or increase in cylindrical powers do suggest progression of keratoconus or any abnormality in the cornea. However, that again is in advanced keratoconus. Then came the placido disc topography, which used to assess the anterior corneal curvature only, now almost become obsolete. Scheimpflug imaging, however, added the details of the stroma, but still can miss keratoconus in its early stages. So what bridges this gap is the OCT. OCT, having higher resolution as compared to Scheimpflug imaging, can accurately assess the epithelial thickness where the epithelium is thinned out and hence help us provide additional information to aid in keratoconus screening even before it's readily visible on the axial maps of tomography or topography. So what we see on the OCT scans on the left is a pachymetry map. To the right is the epithelial map. We can correlate that there is an area of epithelial thinning over the area of maximum stromal elevation or stromal thinning, which appears as a donut-shaped epithelial thinning area. And additionally, the larger maps of the OCT do give an idea of ectasia occurring somewhere in the periphery as well as in case of pellucid marginal degenerations. So swept source OCT adds in advantage as it has better resolution as compared with spectral domain OCT also. Here you can see a clear area. Let me just take the pointer out. Okay. So here you can see an area of donut-shaped thinning of the epithelium corresponding to the area of maximum stromal elevation, indicating an area of corneal ectasia or keratoconus. So apart from just getting to know the maps, there are certain values also available with the OCT-based epithelial mapping, such as the minimum thickness, minimum minus maximum thickness, or the superonasal minus the inferotemporal thickness, that gives an idea so as to whether we can call this an ectatic condition or not. So these are the cutoff values noted. Any values beyond the cutoff limits indicate an abnormal cornea and has to be evaluated furthermore. So enough of the literature. Let's see case one by one. So this is a patient with considerably high cylinder, and on axial curvature map you can see significant asymmetrical bow tie pattern with some skewing. The stromal thickness as well shows significant thinning, and there's a posterior elevation which is well beyond the cutoff values in the areas of maximum stromal thinning, hence giving an idea of keratoconus. This is a clear-cut case of keratoconus where we can readily diagnose it. So additionally, certain machines like the Anterion also gives an objective value called score value, which takes into consideration more than 6 parameters and gives us a value. And the score value more than 0 is considered favorable towards keratoconus. So let's look at another case where the topography appears normal. There's almost near symmetrical bow tie pattern. There is some corneal thinning, however, it doesn't appear to be that significant, especially when we compare with the axial curvature map stating that it's almost normal. Even the posterior elevation does not appear to be significant. So it seems like this patient has a normal looking cornea. However, when he was subjected to an epithelial, even the bad display on the pentacam did not show any significant changes. But when subjected to OCT, we can see that the area of maximal stromal elevation has significant epithelial thinning appearing as a donut sign, indicating that there is an early onset of keratoconus. And such patients, had we subjected them for a laser-based vision correction, say LASIK or any other lenticule correction as well, patient would have ended up in post-LASIK ectasia or post-refractive ectasia. So that is why we need to assess if the cornea is actually normal or has started to become ectatic at certain points, and epithelial mapping does help eventually. Even the score values, which is an objective method, also shows significant high level indicating of keratoconus. Pardon me for the images as I could not get the images of soft copies. So here's another patient who did not have any manifest cylinder. The patient had only a spherical correction of -2 diopters. Initially thought of doing a laser-based vision correction for the patient, but then saw that there was slight thinning in the area. Just to be sure, the bad display was almost asignificant, and again, there appears to be small area of epithelial thinning corresponding to the area of maximal stromal elevation, indicating there might be a certain area of ectasia in the cornea. Now, so how do you further assess these patients when it's proposed to be either keratoconus or not keratoconus? So what next you do is corneal biomechanics. So what it does is release a puff of air on your cornea, deform it, and again calculate the time for reformation and the velocity it takes, and gives you objective parameters of how biomechanically stable your cornea is. These are various values and their cutoff that are to be noted to determine whether a cornea is normal or not. One need not learn it by heart, as the values are readily available in the machine itself. What I'm trying to say is there are various parameters that we need to look at to state whether the cornea is adequately good enough to undergo a refractive surgery or not, or if not for refractive surgery, whether there is any incidence of keratoconus appearing in its early stage. So always a multimodal imaging is better than just labeling cornea as normal or not with just a single scan. So biomechanical strength can be assessed by either Corvis ST, which is from Oculus, or Ocular Response Analyzer. Both are quite good. Combine it with your routine tomography like Pentacam or Heidelberg Anterion or CSO series. and then compare the epithelial and the stromal maps just to see if there are early areas of ectasia. That will give a definitive result to help us decide whether there are cases of earlier keratoconus or not. So to take away, a normal appearing topography does not just rule out keratoconus. Biomechanical weakening and epithelial thinning can proceed much before it is visible on its topography scan. So always do look at epithelial thinning at stromal elevation, which is a precise usable method to assess early keratoconus. When we combine all the parameters of different objective scans like epithelial mapping, biomechanical strength analysis, and the stromal patterns, we get a really good platform to decide whether or not a cornea is weak. And recent incidents of AI has just helped us in leaps and bounds. You can just upload an image of pentacam and the AI does detect whether the cornea is normal or not, though it's not 100% accurate. The accuracy has reached much beyond 85%, and in the coming years, it definitely will help doctors analyze the scans much better. Let's say a practitioner does not have access to all the sophisticated system, and there's still doubt underlying in his mind whether the cornea is normal or not. The best way to assess any doubtful cornea is to wait for 3 months or 6 months, then reanalyze with whatever platform of tomography is available, compare, see if there are any significant changes or progression in the keratometric values, Kmax or thinning, and then decide whether or not to take up this patient for any further procedure, be it treatment of keratoconus like C3R or be it for refractive procedure. A cornea that appears normal may not always be normal. Thank you for the patient hearing.
Thank you, Dr. Abhishek. It was wonderfully explained how to detect keratoconus in early stages and how to use different modalities of investigations for your early detection. Thanks a lot.
Thank you so much.
Kavita, we are taking questions later on, right?
Yes, we'll take it at the end after finishing, sir.
Yeah. Okay. So I now request Dr. Jagdish sir to start his presentation.
A very good evening to one and all. And at the outset, I would like to thank Dr. Rahul and the entire scientific committee and also Dr. Kulkarni for having me today. I think it is wonderful how Abhishek took us through the entire topography patterns and how we could detect keratoconus at a very early stage. So what I would be focusing in the next few minutes is looking at how we understand the disease in a better way and what are the treatments that we commonly use and what are the future directions in some of the situations. And I do not have any financial interest to disclose regarding this topic. So keratoconus is not a disease that has been recent, but it's been detected as early as 1736, and the understanding of the disease has evolved over a period of time. But unfortunately, we know that the recent literature as of 2026 shows that there are about 23.7 million people globally affected with this disease. But it's unfortunate that we've been taught in a residency that keratoconus is still a rare disease or a less commonly seen disease. But in the recent times, we've been seeing a lot of children present with corneal ectasia. And it is also important for us to understand that disease itself is a big burden, not only to each individual, to the entire economy for the patient. So if you look at if a 15-year-old develops keratoconus, look at his entire lifespan. If he lives for the next 75 years, so what do you think he's going to go through with this disease? there's going to be significant impact on his day-to-day activities, and his productivity would be less, and he would be functionally disabled. So if you look at a patient having 6/9 vision with poor quality of what he sees, definitely we do not consider this as a mild disease. And I think it's definitely an onus on all of us to improve the quality of vision in these patients when we detect. So I think it's very important for us to understand what is the burden of the disease. I think this is a paper that we published a few years ago, looking at huge data from the EMR at LV Prasada Institute for all the patients who presented to the clinic. It was over a study that has spanned over 30 years. And if you look at the percentage, it was more males that was affected. And this is a trends that we saw over the years. We did see that there was an increase in the number of people who were detected with keratoconus as the years passed. And it was not sure that whether we are seeing more keratoconus disease or disease is being detected more now because of awareness and the diagnostic modalities that we have. And last few years, it's been like significant amount of increase in the number of patients presenting with keratoconus. And it was, I think, as expected, it was seen in the very early ages. I think up to majority of patients who presented with keratoconus are very young, as you see in this graph. And the mean age has dropped from 29 years to 22 years over the years. And if you look at more number now, I think this would have even come down with the diagnosis that we see in the recent times. And it was seen because of the lifestyle, this disease was more common in urban people, probably because of more exposure to pollution, more allergies, more eye rubbing could be one of the reason as well. And if you look at the treatment strategies, majority of the patients were treated non-surgically. Contact lenses were the prime treatment that we were giving. And we could see that other modalities and among the surgical interventions, collagen cross-linking played a significant role. And if you look at the trends of surgical interventions that were done earlier, it was more of penetrating keratoplasty. As years passed, we did see that collagen cross-linking, which was less invasive, played a significant role, and the need for transplantation decreased over a period of time. And also, we need to understand that the disease understanding and the treatment strategies have evolved over a period of time from 1990s to 2030. And I think at this stage, we are in a position where we could predict the disease, and we're going to personalize the treatment, and we're going to give treatments that could be modifying the entire disease pattern. There's more to come as we move forward. There's more with the artificial intelligence and other modalities that we could be seeing significant developments. As Dr. Abhishek did show that now we know that we can find the cone in the cornea using advanced tomography diseases. Even if you miss on clinical examination, tomography can pick up. Now we need to understand what is the cone going to do now. How is the cone going to evolve over a period of time? Okay, this is the major challenge that we have. So I think it's very important for us to understand what will happen next is what we should understand. So we need to understand that the disease is nothing but biomechanical susceptibility of the cornea because of biological changes and inflammatory factors leading to stress in the cornea, leading to deformation of the cornea, and in turn causing optical dysfunction, that is poor vision, both in quantity and quality. So what is that we do? This is the 5 things that we need to remember. When we look at patients with keratoconus, we need to look at what does the cornea look like. It's very important for us to understand whether this cornea is going to be progressing or it's going to remain stable. If we do not know, I think it's time for us to understand if we can predict the progression. It could be based on severity of the disease, or it could be based on risk factors that are present at that point of time in that patient. So I think we need to then plan how do we change the pattern. If we know that the cornea is going to progress, I think it's very important for us to prevent the progression and preserve the cornea. And it's also important for us to understand not all treatment strategies do fit in each cornea. I think personalization is very important. Once we understand the disease, I think it's very important for us to pick a procedure for each of these patients. So here, when we look at the cone that you see is a physical or a phenotype of it, but the disease is more biomechanical because of the weakening of the cornea. So all these factors lead to structural deformation and the optical dysfunction in these patients with progression. And you need to understand progression is not just limited to one factor. There are a lot of other factors which play a role, the genetics, environment, the behavior of the patient, and the biomechanics that is affected in turn leading to progression. So one of the biggest factor I would say in my entire practice that is see is atopy or the patient rubbing their eyes. Patients feel itchy, they rub their eyes, there's a mechanical stress and inflammation that comes into the eye, and there is biomechanical deformation leading to progression of the cornea, keratoconus. So I think it's always important for us to understand before I think or jump to do a procedure that will stabilize or strengthen the cornea, can I stop the weakening of it? Is a simple question that you could ask yourself because it changes a lot in the perspective of understanding of the disease. Let's look at a few cases here. So here, if you see a lot of kids come to us with this condition, but a lot of them rub their eye. It could be because of allergies, or it could be a habitual eye rubbers. So let's look at a few examples, what we could understand about this. So previously we thought that all these factors like dry eye or genetic conditions, eye rubbing, stress, atrophy, all these are causing keratoconus. But there's this change in understanding that we need to look into where all these factors that are present are in turn causing leading to eye rubbing, and the eye rubbing is the primary causative factor causing corneal ectasia or weakening in the eyes. It's very important for us to understand there's a change in the perspective of thinking in the recent times that the emerging concept is look, all the factors lead to the eye rubbing that in turn leads to decrease in the corneal resistance leading to flattening. How can we avoid? So there's a thing called no rub, no cone. If you stop rubbing, there's no cone. So the progression of keratoconus can be stopped. This is an initiative that has been in vogue in certain countries. There have been awareness programs trying to encourage people to stop rubbing. Let's look at a few examples. So this is a patient's 10-year-old child with chronic irritation in his left eye, and he's been rubbing his eyes, and there's a topography of the right eye which looks relatively normal, and the left eye shows corneal ectasia, and he does give history of left eye being rubbing over a period of time. And look at the change in topography after there is cessation of eye rubbing. So here you can see the topography is almost normalized here. I think the changes that can cause on the cornea, it could be biomechanical changes, it could be epithelial changes, can manifest in the topography as ectasia, and it can mislead us for proceeding with treatment strategies. And it's very important for us to understand and give some time for things to settle down. And this is another patient who has unilateral keratoconus. The right eye, you can see the keratoconus. Left eye looks relatively normal, and you can see the topography of the left eye over a period of time where the patient doesn't rub his eyes. You can see very stable over the period of time. And the patient gives history that he rubs his right eye. And then once he stops rubbing, you can see stability in his topography over a period of time. You can see from 2006 to 2020, his corneal topography remains stable and it didn't worsen. I think taking this history of eye rubbing, the pattern of rubbing is very important. So what happens with the eye rubbing? So I think this is a video that you can see. Sorry. This is a video that you can see that this is an MRI that has been done and the patient has been asked to rub their eyes during the MRI procedure. You can see the impact on the globe when someone rubs their eye, and this in turn leads to mechanical destabilization of corneal structure. And the eye rubbing can intensity or duration or frequency, all this have an influence on the cornea. You can see the serial topographies, how someone, if they're chronically rubbing their eyes, can lead to change in the topography itself. So other important thing that you need to ask your patient is the sleeping pattern. So if, especially those who have unilateral keratoconus, most of them have this ability to sleep on a prone position with their face down. I think it's very important for you to ask them this as well. And there's enough literature showing this. Apart from eye rubbing, even sleeping on stomach or sleeping on the steepest side of the keratoectasia is seen in these patients. This was statistically significant in the same in this study that has been published here from Damian and Gatinel's group. And here you can see this is the multivariate analysis risk factors showing eye rubbing and sleeping in prone position are the risk factors that have been shown here. I think it's important for us to understand, like, there are several reasons for which patients rub, and this rubbing can lead to a lot of bicellular consequences in the eye, and these in turn cause biomechanical consequences as well, and thus leading to changes in the cornea, causing ectasia finally. So I think it's very important for you to understand you can not only stop the development of disease, you can also decrease the rate of progression or stop the progression in patients who have this habit. And this is a small take-home message that you could look at in patients who have unilateral keratoconus. And whenever we see someone having progressive disease, or whenever we want to look for progressive keratoconus, one of the common factors that we use, we jump to few factors. One is we look at Kmax as one of the common thing in most of the practices. Most of the literature also shows this as a factor that is being looked at, and it's very inconsistent in most of the studies. But it's very important for us to understand that it's not enough for us. This value itself is not enough for us to label as progression, because there are a lot of structural changes in the cornea that happen. We should look at anterior and posterior curvatures and elevations and thinning of the cornea, and refraction is one of the parameter as well, and change in visual acuity is one thing, aberrations and biomechanical strength of the cornea. All these factors have to be taken into consideration for us to label someone having a progressive disease. So here we did a study here looking at how can we predict progression of keratoconus, and this is published in European Journal of Ophthalmology a few years ago. What did we do here is we looked at all the topography images and looked at how this changed over a period of time. We removed all the values, just looked at the color patterns. This is how we picked the images from Pentacam. And then these images was processed using deep learning. And at different visits, these images were compared to see if we can do early prediction. This is the methodology that we use, not only
Sorry to interrupt. Can you just please increase the volume, sir, please?
Certainly, sir. We will do that. Thank you. Apart from looking at tomography images, we also added other factors like age, allergy, gender, refraction, and visual acuity as well into the analysis part to look at how this was affected over a period of time. And we included about 1469 patients, and there were more males, and there are some of them with allergies, and we looked at over a period of time. And this is the final results table. I would say if you look at predictive model, and these average values is nothing but the number of months we were picking up changes. And onto your left, the column showing the gold standard way that we were looking at keratometric progression. This was a number of months where the disease was being detected. So it could be more age as an influence, the gender had an influence, Number of people who had allergy had an influence. The severity of the keratoconus had an influence. Visual acuity, refraction, and the astigmatism also had an effect. So every parameter, if you looked at, we were able to predict keratoconus much earlier in this model compared to the gold standard that we use keratometry as a parameter. And this is the bar chart showing how many months earlier we were able to predict with this model compared to keratometry, that we were able to predict significant numbers in the early stage itself. And we also looked at how much visual impact it was causing by detecting early. So by detecting early, we were able to save the amount of visual loss in these patients. You can look at the graph showing that patients, if we would have detected earlier, we would have saved or a decrease in the vision in these patients. I think the future is going to be this way, where we're going to look multimodality in detecting not only the disease and also predicting the progression as well. So when we detect progression, what do we do? So we're going to divide them into low risk cases where we just want to observe them. If there are some patients we're not sure if it's going to progress, we follow them very closely. When we see them that they're progressing, then we intervene by stabilizing the cornea. When someone needs visual rehabilitation, that has to be addressed as well. In advanced cases, we do procedures that can reconstruct the cornea, or replacement of the cornea can be done. So in this decision, we need to make an algorithm that will help us manage these patients. This is a simple algorithm that could be followed. Like if we look at someone is progressing or not progressing, and based on that, you can take a call. But we need to understand, we need to take certain factors into consideration at presentation. It could be the age, it could be systemic association, and it could be someone who cannot follow up as well. In mild cases, if you have good vision, you can just do a cross-linking and give them glasses or contact lenses. Someone is unhappy with vision and have good thickness, you can go ahead and do cross-linking it with augmented procedures like intracorneal ring segments or PRK. If the pachymetry is thin, we do have in the recent times other modalities to cross-link, but otherwise the treatment was always been doing a keratoplasty, where we could go ahead and do a keratoplasty in these patients. In severe cases, whenever someone has severe disease and they have happy vision with glasses or contact lenses, we go ahead and give them cross-linking and then give them glasses. With contact lenses, we'll always give them cross-linking and intracorneal ring segments wherever possible. If the vision is good, we can always give them phakic IOL implantation so that they get good vision without spectacles. In unhappy patients with severe disease, where the vision is not good, and if they have no scar, we can always consider utilizing cross-linking intracorneal ring segments and give them glasses or contact lenses, preferably contact lenses most of the times. And if they have scar, I think it's always good to jump and do the keratoplastic procedures than doing any of the other modalities. And if you have patient is stable, we just observe them. We follow them over 3 months at the first visit, and then 6 months, and then make it annual examination. There are no risk factors. This is a small algorithm that you could follow to give treatment to these patients. And we know that I'd focus a little on cross-linking because that is a game changer here. And a lot of us do cross-linking across the country. And we need to understand that before cross-linking, we were just observing and look at the progression. We are doing a transplantation. And after the cross-linking, we are now detecting early, we're stabilizing it and preserving the corneas as well. So what does success mean here? Like biologically, there's no progression. Structurally, the cornea is going to get stable. Optically, it can have subtle improvement in the optics. Functionally, this vision is going to be stable over a period of time. So let's look at what happens to these parameters of the cornea or the vision or long term with corneal cross-linking. This is a study that we did at LV Prasad Institute, looking at how accelerated protocol of cross-linking affected in patients for a long term. So we picked a lot of patients, 1966 patients. After all exclusion, we had about 1913 patients, and we did epithelium of cross-linking. We used based on the thickness isoosmolar riboflavin or hypoosmolar riboflavin, and follow-up was done every 3 monthly. And we picked patients till 5 years, and we looked certain parameters in the topography and also refractive errors. And this is the changes in keratometry, the maximum keratometry. If you look at the steepening of the cornea initially, and then the steepening over a period of time flattens, and this gets plateaued over a period of time. This is what we've seen. And if you look at the mean keratometry, also follows the same trend. I think it's very important that you counsel your patients as well. Don't panic when the topography shows steepening, and then it stabilizes over a period of time. This is astigmatism as well. And if you look at it, it steepens and then slowly flattens, and there's a plateau over a period of time. And pachymetry, there's a steep drop initially, and then slowly it increases, and then you can see a plateau over a period of time. And visual acuity, you can see there's worsening initially, and slowly there's an improvement over a period of time. I think these changes have been very gradual, and I think it's important for you to counsel your patient that this change can keep happening. And spherical equivalent, I think it's going to be relatively plateau, and it can change over a period of time when there are changes in the topography. And we did see some changes in the spherical equivalent, but we did not see a statistically significant difference here. So when we compare hypoosmolar and isoosmolar, significant flattening was seen with the hypoosmolar riboflavin, and there were at least 2 lines or more improvement in hypoosmolar riboflavin compared to those who were using isoosmolar. And if you look at severity, and there was more changes in patients with severe form of keratoconus than the mild ones, and greater amount of flattening was seen with younger patients than older patients. I think accelerated cross-linking shown to be safe and effective treatment for stabilization of keratoconus, and severity of disease and age do have an influence on the final outcome. This is with plain collagen cross-linking with no addition of other treatments that we do. We always have different options to choose when we are doing collagen cross-linking. We're always confused. Do we go with standard or accelerated? What about thinner corneas when a presents with us? When do we use hypoosmolar? When do we use isoosmolar? And epi-off and epi-on cross-linking. And there's been a lot of buzz about use of oxygen on epi-on and how does it affect. And in the recent times, there's been talks about customized collagen cross-linking, and we are seeing some results as well being published in the recent times. This is a table. It's a big table, but just pick a few points here. We don't have to go through everything. What are the options that are present when we want to do cross-linking? Gold standard thing has always been the Dresden protocol that we've been using. And among the accelerated, this is with 9 milliwatts and 10 minute. I think this is one of the accelerated protocols which has been shown has good evidence showing that it's very efficient as well. And if you look at hypoosmolar, if you look at the cornea is never the same when you have swollen the cornea. It's a temporary swelling, and the efficiency and the number of corneal lamellae exposed to UV rays would be less. So definitely there's uncertainty in the efficiency of this procedure that we see. And definitely we need to keep this in mind and talk to our patients whenever we are using. And epi-on definitely did show that it is less efficient than the epi-off. With the advent of oxygen, it is shown that it is efficacious enough, but the evidence is just coming out, and we need to follow up patients for longer period for us to understand this better. And I would say one of the favorite thing that I've been doing the recent times in thinner corneas is sub 400 microns protocol from Switzerland. This has been published and shows that you can decrease the fluence or change the fluence based on the thickness. That will help you to cross-linking. So number of patients that have been done is limited, and there's still a way for us to look at if this is going to be efficient for a long term. And customized cross-linking has been talked about, and I think it's the future going to be this, but I think it's important for us to understand it's very initial and the results have been very heterogeneous, and we need more long-term follow-ups to see the efficiency of these procedures. And if you look at closely options available for thinner corneas, there have been other methods as well apart from what we discussed. So I think contact lens assisted cross-linking as well in order to increase the thickness. So, but it has been shown that the efficiency is less, and this is because the UV rays penetration or riboflavin penetration could be less with the contact lens available here. And there's been also another technique where epi island or customized epi off, where amount of epithelium in the thinner area or cone is left behind, and then cross-linking has been done. It's technically demanding to identify this area. There's less evidence for us to see as well. There have been also lenticle addition or lenticle augmented cross-linking procedures. I think there's little literature that is available. I think it'll take time for us to see how this is going to evolve over a period of time. And we've talked about epi-on and oxygen enhanced. I think the future is going to be customized cross-linking. I think whatever you do, the goal is you can either swell the cornea or augment with tissues or reduce the dosage of UV rays or customize based on the cone. But the goal is get your corneal thickness appropriately and give an effective endothelially safe dose of UV rays to the cornea. This is the final thing that we have to do, and we can pick and choose how we want to do that. This is a small flow chart that you can take home in progressive keratoconus. You need to measure the corneal thickness after the epithelial removal. If it is greater than 400 microns, it's going to be standard protocol. If it is less than 400 microns, I think you can use hypoosmolar or contact lens assisted cross-linking, or you can look at other customized approaches. And if you think the thickness is less than that, I think you can go ahead and do sub 400 micron protocol or customize fluence or tissue augmented strategies. So you can pick and choose whatever you want to do in these patients based on what is the final outcome you're looking at. So among all these, like we've talked about only cross-linking, but we know that not only stabilization of the cornea, we also have to do visual rehabilitation. Whenever the corneal thickness is adequate, we will always augment certain procedures to it. One of the common one has been topo-guided pre-RK. We are not only stopping the progression, we are reshaping the cornea. And the other thing is intracorneal ring segments or CARES, the allogenic intracorneal ring segments that have been used. And in cases of scars, we use cross-linking with some amount of PTK as well. The goal has been biomechanical stabilization and reducing the irregular astigmatism and decreasing the higher order aberrations. So we are doing both stability and optical rehabilitation as well. So topo-guided PRK has been done for quite some time, and then we've been a better understanding that we do. And this is a quick indications that we choose the patient, the thickness has to be adequate and less irregularities, and we don't do more than 50 microns of ablation, and we need to counsel the patients very well. Very thin corneas and severe decentrations and unrealistic expectations are not a good candidate, and we need to be careful when you're choosing these patients for these procedures. So what is the goal here? We're going to decrease or flattening the cornea, control the astigmatism and the aberrations, thus improve the quality of vision. The corrected visual acuity usually improves by a few lines, and the quality of vision definitely improves. And with the use of cross-linking, the progression is going to be definitely under control. This is one of my patients. Like we'll look at this is the topography before pre-op and post-op. You can see regular changes, and then you can see the topography showing flattening as well. And you can see the aberrometry changes at the bottom, showing that cornea has been much better aberrometry wise post surgery. And this is the visual function map from the pentacam AXL wave. On the top, you can see the pre-op. There you can see the cornea being very irregular, and the final total vision that you see is very hazy. And whereas at the bottom, you can see a post-op, you can see significant change in the corneal aberration. So the cornea becomes more regular, and the final vision the patient can see, or final image, is much sharper and clearer in these patients. So definitely it does help in a small subset of patients. I think we need to pick these patients and do this. The next procedure is intracorneal ring segments. This is synthetic segments, or corneal allogenic intracorneal ring segments, or CARES, that is being used in the recent times with a lot of modifications as well. The goal here also is reducing irregular astigmatism, flattening the cornea, improving the functional vision or contact lens tolerance. So these are the indications that are pretty much the same. We look at good thickness and have a good amount of irregular astigmatism, and look at a cone that is amenable to regularization. And counseling is the crux here. This is less predictable, so we need to counsel the patients as well and make sure you follow these patients with some, if there is any scarring, better to avoid any of these procedures because they don't behave as you expect. So differences between the intracorneal ring segments and the CARES is this is more synthetic, that's allogenic corneal tissue. There's a little bit of customization that we do with CARES that we can use, and there's biological integration of the tissue and reversibility. If you look at intracorneal ring segments, is really reversible in cases, whereas CARES will be a little technically challenging to reverse. I think the CARES is new, it's evolving, and the results, we need to see long-term follow-up and see stability of these corneas over a period of time. So one more confusion that we always have is, do we do simultaneously the cross-linking or ring segments, or do we do a staged one? So I think one of the advantage of doing simultaneous is it's quick recovery for the patient, and it's been shown that the results are comparable. But I prefer doing staged one. I do intracorneal ring segments. When the thickness is good, in the second setting, what I do is I use topo-guided PRK to correct some amount of irregularities or some amount of refractive error, and then do cross-linking at the same time. By doing this, I'm getting a chance to correct more refractive error, making the cornea more regular, and then give it better visual outcomes. But the studies have shown that these two methods have been comparable. So there are other intrastromal allogenic inclusions as well. I'll not go in depth into all this. There are a lot of them that have been published, and it's like very few of them have long-term follow-ups. There are very few of them have some studies available at this point of time. Some of them have been discontinued or not being in vogue, and some of them have been modified and being evolved over a period of time. So these are the details. How do we prepare the donor and recipient? And I think some of them can be replicated wherever possible. One of the common thing I've seen them do this is women's layer transplantation, and we've done a few of them as well. So this is done with very severe corneas where you can't do any other procedure than transplantation. This is to avoid or postpone the need for PK or DAL. How is it done? It's done in two ways. You can do a manual technique or femtosecond laser assisted. So we remove the epithelium, and then we score the Bowman's membrane in the periphery in the manual technique, whereas in femtosecond on the right, you see the laser itself does the cut, and then you can peel it off. It's very technically challenging to do the manual technique, where you do and take a needle and then you score on the periphery, and then what you do is you take you lift the Bowman's membrane and then use a forceps and try to peel off. Bowman's membrane is very strongly adherent to the anterior stroma, and it takes a lot of time to remove it. Once the tissue is prepared and we make a pocket in the cornea, And staining with tryptophan blue, we push it into the pocket using a femtosecond laser. This pocket is created, and then once it's pushed into the cornea, and then we spread it out and then seal the wound. Okay, technically preparation is very difficult, but insertion should be able to be done pretty easily. And there's a minimal amount of studies that are available. Most of them are from similar group, that's Mallay's group from Netherlands, where they've shown there's a flattening of the cornea and decreased progression as well. And the number of complications has been less with these cases. And this is a topography showing a stabilization of the cornea here. And this is one of the study that I'll skip this. This is one of the study from LVP where we use porcine collagen. This is similar. A collagen implant is fashioned and using a pocket in the cornea, using a femtosecond laser. This implant is injected into the cornea. So this is prefabricated implant, and then you put it into an injector, and then we inject into the pocket, and then spread it out like how we did a bone transplantation. This is how it is done, and then this is the post-operative follow-ups. You can see that it's pretty clear, and over a period of time, this is a OCT showing this some amount of flattening, and the implant has been well in place. And this is the topography showing a significant amount of flattening that you see in the cornea, pretty significant. But this implant, this is a long-term follow-up that we've seen, but this implant also had some issues, and it's not it's been modified right now. I think it's not used on a regular basis. So these are the some of the techniques that been using. But when we cannot do any of these, keratoplasty is only choice, and I'll just focus on talc here. So deep anterior laminar keratoplasty has definitely advantages over penetrating keratoplasty. Over a period of time, you've seen that it was technically challenging, but because of its advantages, many surgeons prefer to do talc over a PK. So I think selecting the patient is very important, looking at advanced keratoconus and who is having good endothelium and not suitable for contact lenses or not tolerating contact lenses. We can consider, I think looking at age is very important. Very young patients have active disease, and they may have allergies, and it can have significant vascularization and quicker loosening of sutures. I think we need to be careful when you're selecting these cases. Someone beyond 25 or 40 years, I think they're more stable disease, and then they would do very well with with their procedure. So age does have an influence, and I think it's very important for you to counsel and explain your patient. It's very important for you to know when to operate. Whenever someone is not happy with the contact lenses, then only you should operate. And I think you need to understand that you need to make sure that the vision cannot be improved with other methods before you proceed with the surgery. So this is a very important point where whenever you look at the patients like this, ask them for contact lens history. So this is a patient who presented with a scar in the cornea, not happy with their contact lenses. And if you look at OCT, this is a scar in the anterior stroma, epithelial hypertrophy. This is an entity called keratoconus nodule. This is less commonly seen, but patients on chronic contact lenses do have this. Don't jump into transplantation here. This keratoconus nodule can be just cleared with minimal amount of PTK, phototherapeutic keratectomy that we do on the cornea. For this patient, we did the PTK, and you can see the cornea has become more regular. And then this is OCT showing pre and post surgery. The cornea is very regular now with minimal amount of scarring. So epithelium is regular. So patient went back to contact lenses, and he didn't need any surgical intervention other than a PTK. So someone having allergies or dry eye, it's very important for us to treat these before we go ahead and do a transplantation. Slit gland assessment is very important to look for scars or vascularization. Someone had a eye drops, that history definitely helps you. Looking at the cone location and the magnitude of the cone is also very important. Tomography evaluation, looking at pachymetry map, looking at the cone type and thickness, and decentration is very important because it'll help you plan the surgery for trephination. So depth of the scar is very important, and looking at the descemes membrane is very important. Sometimes if someone had the high drops, DALC would be technically challenging to do. So if they had dame rupture, getting a bubble is very important. We have to resort to manual techniques here. So identifying a clone location and the magnitude, size of the cone is very important here because we have to include the entire cone into the trephination so that you do not have recurrences. This is a patient who had a keratoplasty, full thickness corneal transplantation, presented with corneal ectasia. The bottom you can see in OCT, you can see that there is an ectatic cornea and thinning in the periphery. And then when we did the transplantation, looked at the histopathology, you can see the graft junction had an ectasia, and that was not included in the previous graft. So now we had to prepare a larger graft. And I think it's very important when you see its slit lamp, look at the Fleischer's ring, and you can always merge your topography over it and see the size of the cone, and then include the entire cone so that you remove the entire ectatic cornea. And it's also important for you to understand if any surgery was done before, because these have an influence on the surgical technique as well. If someone had a cross-linking, it is important for you to understand the cornea is more compact, and doing a procedure or doing a big bubble technique would be more challenging. And when you have other procedures like intacs or prior ALK, you need to modify the technique as well. So let's look at a few examples. This is a patient who had intracorneal ring segments, and you can see his vision in the left eye has been very poor in spite of this, and he was not happy with this. So he came for the surgery. So we had to do a deep anterior lamellar keratoplasty. We used a femtosecond laser to make the side incisions, and then we are doing a big bubble. We did not remove the intracorneal ring segment, so we just injected a bubble. We got a big bubble, and then what we did was, now the entire complex of anterior cornea and the intracorneal ring segments were removed. And then this is a brave slash where we give an incision on the anterior stroma. And then what we did was we gained access to the descemes membrane, and slowly we went ahead and removed entire posterior stroma, and we sutured the graft there. And post-operatively, the patient did very well, and his vision improved significantly. And this is another patient who had anterior lamellar keratoplasty earlier, and you can see residual amount of cornea, and his vision was very poor in his left eye and not happy with his vision. So we had to do a full thickness penetrating keratoplasty or a DALC. With such thin residual stroma, doing a DALC is technically difficult, but we tried doing the DALC itself for this patient. So removing the previous graft is pretty easy. And then once we remove, we try to do a big bubble in this patient. So you know that the thickness is very less. So here we didn't get a big bubble, but we got some tiny bubbles. So we tried to gain access, but we saw that there was a perforation when we were trying to gain access, and the bubble in the anterior chamber was escaping, and we can see the aqueous also escaping. But we always know that if we can attempt DALC is always good for the patient. So we found one more small bubble. We're trying to gain access into that plane. We used that bubble, and then we gained access into that plane. And now we see that we are doing blunt dissection, and using scissors, we're trying to remove the posterior stroma. Since there was a perforation already happened, so I think it's very important for us to be very careful here so that we don't extend the perforation and cause a DM tear. So we try to meddle with all other areas away from the perforation before we go to that area. So we removed most of the stroma in posterior stroma, and now we are going to the area where there was a perforation. We can see there, as we try to remove the stroma, the air is escaping from the anterior chamber. And then we're trying to remove more. We just want the visual axis to be clear, trying to pull off the posterior stroma behind. So as much as possible should be removed so that the visual axis is clear, and then you end up doing a DALC for this patient. Leaving little amount of tissue in the periphery is fair enough than doing a full thickness penetrating keratoplasty for this patient. So what we are doing is trying to trim off the excessive posterior stroma in these cases. Okay, and then we went ahead and we left this stroma and went ahead and did the suturing. And this is the OCT. We can see this is the post-operative fourth day, and then you can see significant amount of improvement in the vision for this patient, and the graft is well in place. So I think it's very important for you to understand there are situations where you can have perforations, and wherever you can manage. Otherwise, we'll have to convert to full thickness penetrating keratoplasty. And we'll have to be making a clear decision about whether you do a big bubble technique or manual technique based on the indication. So I think selection of the patient is very important, and surgical technique modification is very important for us to do a very successful deep anterior lamellar keratoplasty. So one last topic, I'll take another 2 to 3 minutes and then end this talk. Here, one of the common thing that we see is patients presenting with irregular corneas or ectasia and cataracts, and how do we deal with this? So you have a disease that we well understand, that is keratoconus, and we have a disease that is cataract. And how do we deal with when both of them are combined? Can we achieve such a good outcome, not only optically but visually as well, is what we should look at. So cataract surgery assumes that we have the outcomes have been very good. So we know that we are operating on doing refractive surgery with unreliable corneal data. The cataract surgery is very successful when we have everything in very good. And keratoconus, you know that all the parameters are deranged, the anterior posterior corneal ratio, keratometric index, and it overestimates the corneal power. Effective lens position cannot be calculated, and decentered apex is one of the big causes as well. This will in turn lead to higher IOL power prediction errors, greater hyperopic surprise, poor toric predictability in advanced disease, lower refractive accuracy that we see. So I think taking a proper history is very important. Measurements are very important, and we should understand IOL power selection issues. Counseling plays a crucial role, and there's some surgical consideration as well, which we will discuss. So we have to have a properly measured tomography, and then look at if there are any scars. Cone location is very important, and also look at stability of the disease. And also, if someone has used contact lenses before, understanding their vision before the development of cataract is very important. If you look at about all the measurements, I think keratometry, there's significantly reduced repeatability with this, and it has been shown that flatter keratometry is better predictable, and posterior cornea is there's significant discrepancy in the posterior cornea measurements that we get, and the total cornea measurements do help in improving your calculations. And if you grade the keratometry into different grades, the keratoconus, you know that milder disease performs very well. In case of moderate disease, you need to understand this variable, but I think getting good measurements, you can still get a better result. Trying to aim for more myopia is very important. In severe cases, I think you need to understand the data is less reliable, and formulas also, most of the formulas do not work, and trying to give more myopic prediction is important for these patients, and counseling them for the need for contact lenses post-surgery is important. So when you have an astigmatism, should we do toric or non-toric is important discussion that we usually have. So usually astigmatism in keratoconus can be regular anterior astigmatism. Irregular astigmatism mostly seen with higher eye order aberrations and posterior corneal contribution. Toric IOLs only corrects the front part of the cornea, and they do not correct the other parts of it. So I think we need to counsel this patient when you are planning a toric. And in case of torics, it's very important for you to understand. In mild keratoconus, it definitely works in majority of the times. In moderate, you need to be careful in selecting the case. There can be variable refractive accuracy. And where advanced cases, definitely it's going to be very unpredictable, and I think it's very important for you to avoid. Sometimes we also do to regularize the cornea with PRK and then do a cataract surgery as well. When the surface is better, the predictability of cataract surgery is better, the need for contact lenses post cataract surgery also reduces in these patients. I think whenever we take measurements, first thing is keratometry. Where do we take keratometry from? In milder cases, most of the cases, we can take a SIMK or total keratometry. In moderate cases, we may not get, most of the times, biometry. Tomography-based keratometry can be taken. And in severe cases, we may not, the measurements can be very unreliable. I think adjusted or standard keratometry is used most of the times, and putting more myopia target would be a better option here. And among the formulas, the different formulas that we have, and this is a list of formulas and the performance. Let's look at some of these. If you look at the prediction of plus or minus 0.5, we do see that Barrett's true K formula with measured posterior curvature and RBF have been doing pretty well with 62%. With plus or minus 1 diopter predictability, you can see both these formulas did well with 81% and 78% within plus or minus 1 diopter. And if you look at the error, mean absolute error, and this has been better as well with these formulas only. I think Barrett's true K value with measured posterior curvature, where you can incorporate these values in the APACRS calculator that you have. You can measure the posterior curvature from the pentacam or any other tomography, and then incorporate these in the calculation system, and then it gives you the calculations. So you can use this for your patients. And top formulae that have been performing well was, this is order, Barrett True K with measured, and Barrett True K with posterior predicted corneal curvature. And Keynes formula also has been doing very well, and it's an online calculation system. You can always use this. So regarding IOL selection, do we use aspheric or negative spherical aberration IOLs? Yes. In mild cases, I think they do help in correcting the spherical aberration, but in moderate keratoconus patients, I think it's very important to not use these cases, and always using spherical lenses would be important in this cases. And regular astigmatism or less irregular astigmatism, toric lenses would be a better choice as well. So predictability decreases with severity. I think it's very important to counsel, and more hyperopic shifts, possibility of residual cylinder, need for glasses and contact lenses should be counseled, and presbyopia correcting IOLs should be contraindicated in these situations. And surgical implications, because the cornea is very irregular, when we go on look through the irregular cornea, looking at the cataract would be very difficult. So this is a paper that has been published looking at the irregularities on the anterior surface of the cornea with and without contact lenses. So this is a patient who had severe keratoconus, and then he wanted a cataract surgery, not keen on transplantation, was happy with contact lenses. Now he developed a significant cataract. So we were doing a cataract surgery. Doing the cataract surgery, we found that it was difficult to judge the depth of anterior chamber. So we were not able to reach the capsule. So we were finding difficulty, distortion of instruments. So what we did was, I just put a contact lens that patient was using. So we just soaked it in antibiotic and then cleaned it and then put it on the cornea and then wet the head and did cataract surgery. You can see the area where there's contact lenses and there's no contact lenses in the cornea. You can see the distortion of all the instruments. So it was very difficult because the contact lenses is a smaller one and it was moving all across. So we had to do very careful manipulation here, and a monofocal lens was implanted in this patient. So if you look at, I think cataract surgery is technically difficult. More pre-op planning plays a crucial role than the surgery here. And the outcomes depend on the stage, and there are surprises, and your counseling pressure crucial role with these patients. There is definitely a scope of improvement with future, the AI-driven formulas that are coming and the ray tracing technology and incorporating higher order aberrations into the IOL selection would be one of the most important change. And there is some literature that is coming up in the recent times. So this is what I have. I try to cover most of the things, but there's a lot that we can talk about it because each topic is a long discussion that we can have, and I'll be happy to take any questions that you have at this point of time. I'm sorry I would have gone a little overboard with the time.
Definitely. Thank you so much, sir, for that, giving us all the flow charts and an extensive description of all the treatment modalities of the keratoconus, almost like an 360-degree view of an keratoconus and its management, right from C3R, which is being done by all the ophthalmologists and very helpful to all the keratoconus patients, to the advanced procedures or using Athens protocol, or be it a DALK surgery or a Bowman's membrane transplant, or coming to the keratoconus along with the cataract. So thank you, sir, for having that extensive view of keratoconus for all our audience. Thank you so much. When sir is already talking about eye rubbing, I would like to ask our panelist, Kulkarni sir and Lande sir, that what all treatment do you suggest to your patients? Because only stopping eye rubbing or just telling the patient not to rub the eyes doesn't suffice the treatment. So we need to put something more. So over to you. If Kulkarni sir is there.
So, thank you, Dr. Kavita. First of all, I congratulate both the speakers for extensively covering and highlighting the importance of not rubbing the eye to prevent progression. So, most of the time, our clinical practice, the commonest causes are uncontrolled allergies, very severe patients presenting very early, or those patients who spend a lot of time in front of the screens. Most patients who are working as software professionals. And there, the cause of rubbing is induced dry eye or evaporative dry eye causing irritation. And the moment they rub the eye, they feel better because the meibomian glands are pressed. It releases the lipid and improves the surface and comfort. So the brain registers that by rubbing the eye, they feel much better. So we have to first find out what is the cause of the eye rubbing, why the patient is rubbing the eye, and then tailor your treatment accordingly. Most of the time, it is the allergy, but we should also have a very close eye on disturbed tear film because of the professional hazard.
Thank you, sir. Thank you. Any other comment from the panelist?
If Lande sir is available.
So you have to treat the
Hello,
allergy very, very. One has to
Aggressively.
be. So
yeah,
the
I have
allergy
one
needs to
question
be
for.
treated completely, because otherwise all other treatment is not going to help. And even after cross-linking, if the patient keeps on rubbing the eye, there are reports which say that the progression can still happen even after cross-linking. So it does not mean that if the patient has undergone cross-linking that he can easily rub his eyes now. So that also has to be driven very, very clearly to the patient and the family.
Lande, sir, I think you were asking something.
Yeah, I have a question for Reddy sir. See, many times we do a C3R and we noted that the vision drops by a few lines, and which doesn't come to the normalcy many of the time. So I have always a question or a thinking whether should I operate somebody who is having 6/9 or 6/12 parts vision, and the quality of vision is better, and I find that goes down once I perform the C3R. This has happened to 2 to 3 times to me, so I'm slightly doubtful about doing C3R in early keratoconus cases or cases with a good visual acuity. Can you elaborate it?
Yeah, the different causes that would be the reason for this. One is, I would say, like calibration of your device is very important. We've seen situations where the calibration has been the major concern. Number two is most of the times we remove the epithelium or we get out from there and we ask our technicians to continue the procedure. The sister continues most of the times, but I think we need to understand, like, if the cornea dries through during the process, there are a lot of changes that happen in the collagen that we don't understand post surgery. I think it's important for us to ensure that riboflavin is put at a regular intervals and the cornea remains wet or moist throughout the procedure is one of the very common thing. And post-operatively managing inflammation is very important. Following them up closely, making sure that the inflammation is under control and there's no residual haze or scar, because we do see some patients develop CTK after collagen cross-linking, and then we end up seeing them having trace haze and that will have a subnormal vision. These are the few things that if you could follow, most of the patients would get back to what vision they had. Only some of them who have trace amount of haze, or some of them who are irregular with the steroids initially, are the ones would have a longer, they take a longer time to restore their vision to normalcy. But otherwise, most of them would get back to what vision they had pre-surgery.
So as we are on this point, my question again is, your data showed that the hypoosmolar has been doing well as compared to the isoosmolar.
Yes.
So would you consider hypo for all the cases?
No, I don't do hypo. Like it's an excessive flattening. There are people who had 7 diopters or 8 diopters.
Uh,
So they predict
so
it to
many
be
times
on an average.
yeah,
Sorry.
intraoperatively, one of the observation is that when you are using hypo, the cornea tends to dry faster as compared to when you're using a ISO with HPMC or Dextra. So what I do is every 2 minutes hypo and then every 3 minutes put a drop of uh, water for injection or distilled water. That also helps in swelling the cornea. And this has been my observation also, that the flattening you achieve with hypo is much pronounced as compared to the ISO. So I'm just
Yeah, the
toying with the
flattening.
idea. If you really want to have a very good effect, why not use hypo for all the cases? And with the additional advantage of the cornea getting swollen up during the procedure as well.
Yeah, that can be done. So I think monitoring the
Thickness.
thickness of the
Yeah,
procedure very
yeah,
important. I think if you're
yeah.
doing that, I think these customizations do help in getting the final result, whatever you want to. Yeah.
And another important point which you made, I would like to highlight and stress again, is the calibration of the machine before every procedure. Before every procedure, that is important. If you are lined up 2 or 3 cases, you can't just take it for granted that the energy delivered is the same for all the cases. So before every procedure, it needs to be checked. That's a very valid and important point you have made it.
Yeah.
Thank you, sir.
Also, we have
Yes.
received 2 more questions. Dr. Neha.
Yes, I would like to ask question to Dr. Abhishek. Sir, there is a question saying that biomechanical methods are nowadays coming up as a very early detection for the keratoconus. So how will you use them and how important they are to diagnose as well as prevention of misdiagnosis?
Madam, that's rightly said. Biomechanical changes are the first to appear in the cornea much before any other detectable change, in case of keratoconus at least. So we have 2 main instruments to detect the biomechanical strength. One is ORA, ocular response analyzer, and the second one is Corvis ST. The advantage of having Corvis ST is the smaller footprint and its ability to integrate with the existing Pentacam, because both are from the same company or the family. So Corvis ST has its own parameters like the deformation time or the velocity with which it comes back, the rebound time, and it gives an objective index as well. Additionally, we can combine both the tomography scans from the Pentacam and the biomechanical indices from the Corvis ST, and it will help in much more better understanding of the cornea in terms of its biomechanical strength, and also lead us to the direction whether, as in, we're supposed to proceed further with the refractive surgery, or if we are considering diagnosis of keratoconus, doubtful cases where the maps are not that obvious for keratoconus, it will also help us guide whether or not the patient is having keratoconus.
And how to prevent overdiagnosis?
Whenever in doubt, it's always better to wait for at least some time, let's say 3 months, and then decide if there is actual progression or not. But again, in the basic idea in addressing the diagnosis much early is that we can salvage whatever vision is there at that point of time. And in very early cases, I think 3 months would not make much of a difference.
Yes.
Only if there is sure shot values, like the indices are going much beyond the cutoff values, and you are very sure that the patient is having keratoconus, only then we do proceed with either cross-linking or any other modality of treatment. Or else, if you're still doubtful in spite of all the observations in various modalities, it's always better to wait.
Thank you.
So my question regarding the same modalities of treatment. No, everybody does not have access to these
Always.
investigative modalities.
Yes, sir.
We are basically doing serial topography. Going by what you presented, the epithelial thickness map. So do you also do epithelial thickness map at every visit when you are repeating topography to see or look for progression?
In the sense, after the treatment or before the treatment,
No.
just assess
The patient
progression?
presents to you, you do a baseline epithelial map and then say repeat topography after 6 months. So do you repeat
I do
epithelial maps
repeat
also?
epithelial mapping at that time as well, sir.
Yeah. If the stromal part remains stable and the epithelium thins out, would you consider early cross-linking in these cases?
No, I would still wait again until the stromal elevation increases.
So that is the main point, which will be the deciding factor, right?
Yes. The epithelium thinning is a secondary modulatory change that we can see, and not the primary pathology in the disease progression.
Yeah, but it is secondary to what is happening at the stromal
Underlying
level.
stroma, yes.
Dr. Jagdish, I would like to ask your protocol of following 3 months or every 6 months. You in your algorithm, you showed
3 months.
that when you have a very strong suspicion, not very sure, then you would like to see the patient every 3 months rather than waiting for 6 months. Because many times you must have had, or I think everybody must have had this experience that you ask the patient to come back after 6 months and then you realize that, oh, the cone has increased. I mean, would have seen earlier where the stromal thickness would have been 10 or 20 microns more before you take up the patient for cross-linking.
Yeah, I think it depends on the at the time of presentation what we notice. Age is very important.
Yeah.
Risk factors are important, like allergy, the sleeping posture are very important, and the severity of the disease is important. And based on these factors and the thickness and the steepening that we see and amount of asymmetry you see in the cone, all these factors will decide on how frequently do we call. So if I see an younger age patient with any of these changes, I would go 3 monthly. If I see a 25, 26-year-old patient, then I may call him in 6 months as well. So I don't expect much change in that. If someone is above 30, like I'm more liberal with the follow-ups of these patients. I think taking all these points into consideration when you see at the first visit, based on that, you have to customize the follow-ups.
Yeah, that's important. That's an important point. In general, we have seen that if the patient presents before the age of 20 years, they tend to run a more aggressive course rather than somebody who first time presents to you after the age of 20 years. They usually tend to remain stable. And even the asymmetry remains like the cone would increase in one eye, the other eye for years together remain stable. So here the important point of the posture while the patient is sleeping makes a case, because when you ask history, and they would definitely come up with something like this. I mean, I always ask the patient to demonstrate how they sleep. So that time you can pick up these cases, why the one eye is progressing and the other is not progressing. So most of the time, this is if the patient is not rubbing the eye, but there is some other factor contributing to the continued pressure on the cornea.
In the recent times, we do see that a lot of children who come here and they're less They don't listen to the parents, and that's not been there before. Right now, I see that. So,
Yeah.
and calling them if they have any risk factors, calling them every 3 monthly and counseling them is very important. Parents are
Yeah.
very happy if they come at regular intervals and we put the pressure for them not to do certain things. I think that is very important because they're so careless. They say that I'm not able to do it, so they're not bothered about it. So counseling from our side makes a huge difference. The such patients, calling them at every 3 monthly helps a lot.
When we are talking about rubbing or anything, do you still think that there is a very big gray area in the knowing the disease pathogenesis? Because we have come a little far from eye rubbing or having approaches to the pathogenesis part. Do you feel so?
No, I think we've always understood. I think there may be something that we're missing, but I think it is known factor that it's an inflammation that is incited there, and apart from the inflammation causes the biomechanical changes, the inflammation adds to that, and this in turn leads to the weakening of the cornea. I think controlling both of them is very important. I think. Treating inflammation when someone has an ectasia is very, very, very important. I think even the mildest form of allergy should be addressed in a bigger form because you do not take it easy because that has a lot of impact on a long run. So addressing and giving them anti-inflammatory medicines for a long time on a continuous basis until they're a certain age is very important. And I also find cold compresses very helpful. So I do advise everybody who has an allergy and a tendency to put their hands, parents insist them to do ice packs every day, at least twice or once a day, at least that make that a habit so that they don't the hands at all.
Yes. Can we have another question, Dr. Neha?
Can we ask, ma'am?
Sorry. I think, yes, sir. Go ahead.
Yeah,
You can ask question.
yeah. Sir, I've got two questions. One is, as a comprehensive ophthalmologist, I would like to ask, what is the single most important sign in a topography that makes you suspect that early keratoconus and not even if the cornea looks normal? Because we don't have all the gadgets like Corvis and other things. We just have simple topography and that's it. So what will be the single most important sign you will see, even if the cornea looks normal, sir?
Now, suspicious things, there are a lot of changes that will happen. Anything can be suspicious. So you can have an asymmetry in the topography from the anterior cornea. If you have a tomography, you have elevations are very important. So posterior elevation maps would be very helpful as well. So I think it's important to see the curvature, the anterior curvature, and the posterior elevation and how the thinnest point is correlating with these areas. I think we'll have to look at all these changes and then decide on it. It is difficult to say a single number. So this was the teaching that we used to do in the beginning, but I think we've evolved to see that there's a lot of other parameters that change, and we can never depend on one single parameter as a cause. So
the
curvature is the first.
progression is
Curvature.
more important or severity of keratoconus is more important for deciding the cross linking? Because often we see in our OPDs like the patient is not having all the old documents and the PACI is less than 400 and patient has got a keratoconus. So how will we decide at our level? So we should go for a C3R or not?
Now, this is a counseling that you have to do with the patients when there is someone with a thinner cornea. And if they have any risk factors, there's no doubt, then we'll go ahead and do cross-link these patients. But if you think he's 25 years or 28 years, no risks, but it's having a thinner cornea, even observing them regular basis is also fine. We've seen patients be stable for years just with thinner corneas. They don't progress. The progression has stopped after a certain limit and it doesn't progress further. So we don't have to do anything with them. So I think having this counseling, and if you think they're going to come for regular follow-ups, then observation. If you think they're not going to come for regular follow-up and you have any other risk factors, and going ahead and helping them with collagen cross-linking would be a better choice.
I have a question about pregnancy and progression. Can you elaborate on that? Because I have seen, especially post-classic ectasia, ladies, especially after postpartum, they progress significantly. So and problem is treatment also. There are some treatments which we definitely cannot do. So can you just highlight few points about it?
Yeah, it's very tricky. Like we published a few years ago the series from LVP that pregnancy, how many people progressed, but we also looked at different hormones as well. Like we were not able to pinpoint who is the one who's going to progress, and there's not been enough literature. In my entire refractive surgery profile, I've seen only one patient who underwent a flex, and that is before smile, and then completely normal, and then presented with ectasia. So I think it's difficult for us to say that, but this has been a part of all the counselings that we do in women, that there can be an ectasia post LASIK or smile. This has been part of our counseling that we do. But I think there's nothing that we can do to predict them at the time of refractive surgery. But we most of the times we patients present after delivery only, and I hardly saw anybody with changes coming during pregnancy that their vision has dropped. Most of them who came after the delivery, and then when they were lactating, they come saying that my vision has dropped. And by then you would have seen a significant amount of ectasia, and then we do a cross-linking.
Do you do cross-linking when they are lactating as well, or do you wait for them to wean off and then do it?
I think lactation should not be a harmful thing to do cross-linking, but during pregnancy, doing cross-linking would be more riskier. But I think lactation should be safe enough. But the efficacy of it is definitely as a question, because still the hormones have an influence on the collagen, and that itself would have an impact as well. But if you think something is progressing at a rapid rate, you want to decrease the rate of progression, definitely can be considered. But ideal would be after cessation of lactation, and then once the hormones are within the normal limits, going ahead and doing cross-linking would be a better thing.
So when we are on this point, I had 2 or 3 occasions, patients, uh, married ladies, and then they came to me as a couple and asked that we are planning a child, and the cone uh, at the moment is stable, and we understand that it can progress during pregnancy. So is it a good idea to do a cross-linking before the lady gets pregnant?
Yeah, so we did have, it's a counseling that we have to do with the patient. Their patients, most of them would prefer getting it done than waiting. They prefer getting a collar because it's less complex and more predictable procedure. So they would consider, I had at least 3, 4 patients where they would have got the cross-linking done and then went for their pregnancy planning, because
Okay. Yeah,
I did give them tell them that no way I can predict that whether you're going to
yeah,
progress.
that's true. Yeah.
But there is a possibility of progression, and then we'll have to deal with it based on how it is. So some of them understood the condition, and they got the cross-linking done before pregnancy.
Okay.
So after doing collagen cross-linkage, sir, for the rehabilitation of the vision, so how many months do you wait for giving it a spectacle or and scleral contact lenses or any other modality of treatment for that matter?
At 1 month, we do give them contact lenses. So for everybody, I do a contact lens trial pre-operatively, pre-collagen cross-linking. I cross-link only those who are going to use contact lenses. If they're not going to use contact lenses, I'm not going to do a cross-linking, because it's not going to help them in any way. So glasses or contact lenses, if they're comfortable, then only we proceed with the cross-linking. And we have all the measurements taken before, and we repeat them at 1 month, and then we give them glasses or contact lenses as well.
Thank you, sir.
Can I ask a question?
Yes, sir.
Sir, which are the cases where you can actually do the C3R followed by, or at the same sitting, the topo guided PRK, and which are the cases where it should be avoided?
Now, if you have decent amount of corneal thickness and the asymmetry in the cornea is not very severe, and we can consider these patients. So if the thickness is beyond 450 microns, okay, and it should be two ways. One is either you want to correct an irregularity in the cornea so that they get their best corrected visual acuity, or increase the tolerance for contact lenses, or there's an improvement in the best corrected visual acuity. And the other way of doing it is correcting some amount of refractive error. Most of the times we try to regularize the cornea than correcting the refractive error per se, because that 50 microns that you have, most of the times it gets exhausted when you try to do that customization for these patients. So if they have a more than 450 microns of corneal thickness, and if you want to regularize the cornea a little bit, so that if someone is using scleral lenses or you want to get them to RGPs, someone is using an RGP, you want them to get into glasses, this is an opportunity that you can do in these patients. But you should counsel them that there's a possibility they still have to use like contact lenses post surgery. You should not overpromise them and go ahead and do that. And we also did a small study in LVP because there were two debates. I used to do wavefront optimized for most of the patients in the initial period. Praveen used to do topo guided for all patients. And then we compared these results. We found that both were comparable and had not had too much of, probably the selection criteria was different. I was looking at more central cones, not too irregular cones. So central cones in wavefront optimized PRK can help in flattening the cornea and improvement in their best corrected visual acuity as well.
One question, sir, like for the people who are not cornea specialists, which are the patients in which you should not do C3R?
Not do C3R are the ones if you have an advanced disease and the patient is not willing to use contact lenses for visual rehabilitation, there's no point in doing a cross-linking because the procedure is just doing it and is not going to do it. But if the
You are not audible.
I think
we lost the connection.
yeah.
they're not good candidates for C3R because there are a lot of implications, and the cross-linking also will not be an indication. If anybody has an active allergy, I think it's very important for us to control the allergy before we do a C3R as well. And if you have a corneal thickness, very significant thinning, I think they're also candidates where you should not go because of the compromise in the endothelium too. I think for thinner corneas, the sub 400 micron protocol, I think a lot of people have adapted. I think that's been used, and I think recently there's a paper looking at long-term follow-up of these as well. So I think that is one of the option if someone has an advanced keratoconus, happy with contact lenses. I think instead of doing augmented procedures, which are less reliable. I think doing a cross-linking, giving contact lenses, because contact lenses always give better quality of vision. So I've been doing this in the recent times, doing a sub 400 micron protocol and then continuing them on contact lenses.
Did you have any patient who developed eye drops after cross-linking in whatever data you analyzed?
Yes, we did have a few cases. These were advanced keratoconus patients who was to start with, and they had 60 above keratometry.
Yeah. Okay.
These are the ones they developed eye drops post cross-linking too.
Okay. Does it behave differently as far as the natural history of the eye drops is concerned? Does it take more time for the desmet to scroll back and heal without surgical intervention?
The severity of eye drops was less.
Okay.
On OCTs, if you look at the cornea is compact, the amount of fluid accumulation, amount of spread was less. So it has no impact on Descemet's membrane, the cross-linking. So that would definitely help in the faster resolution. But I've not followed them up to look at this, but this was a retrospective study. But what we've seen is OCTs had lesser changes compared to what we see in regular cases. Yeah.
I think we can go ahead and ask few more questions, but we should stop here. Thank you, sir. And back to Dr. Rahul, sir.
Thank you so much for enlightening us, sir. It was a wonderful discussing you. I'm sure there are still many questions remaining, and we can go on asking you questions. But Ajay sir, would you like to, should we conclude, or are there any points to be discussed further?
I think it was an exhaustive presentation. Is already covered almost all the
Yes.
things. Many people, I'm sure, wanted to know about cataract surgery in keratoconus. So he
Yeah,
has very nicely elucidated which care to take, which formula, and which lenses I mean, depending upon the stage of the disease. So that is very important because many times uh, everybody will be facing the refractive surprises after the cataract surgery. So that is very well covered. Uh, I don't think any other point needs further mention.
yeah. So I request Subodh sir to kindly conclude today's session, sir.
Thank you, Rahul. Uh, it is my privilege on the behalf of Vidarbha Ophthalmic Society to propose the vote of thanks for this excellent Viewers Wednesday webinar 8 Keratoconus Unmasked. First and foremost, I sincerely thank our distinguished speakers, Dr. Abhishek G. U. and Dr. Jagadish Reddy sir, for sharing their valuable insights on the early detection of keratoconus and the latest concepts and future directions on the keratoconus management. I was really thrilled with this keratoconus and cataract management. It was really very nice presentation. I think, Rahul, we should conduct one more session for keratoconus and cataract management. Sir, your presentations were highly informative and clinically relevant. My sincere thanks to our moderators, Dr. Neha Deshpande and Dr. Kavita Dangra Madam, for conducting sessions so smoothly, and to our esteemed panelists also. Dr. Ajay Kulkarni, our own corneal surgeon, who is a savior for all the corneal diseases, which we refer him from all our districts to him. Then Dr. Pankaj Lande, an innovative surgeon. Dr. Ankit Harwani, upcoming surgeon from Amravati, and my friend Dr. Nikhil Kandurwar, a pianist, for making the panel discussion so engaging and enriching. I would also like to place on record my appreciation for our US Scientific Committee under the leadership of Dr. Rahul Tiwari, with Neha Deshpande, co-chair, and all the committee members for conceptualizing the organizing and academic initiative. A special word of thanks to our president, Dr. Shon Chinchole, for his enthusiasm and the constant guidance and encouragement to all our US office bearers for his support. We are also grateful to Entod Pharmaceuticals for supporting this academic program and helping us bringing meaningful education initiatives for all our members every month. Finally, my heartfelt thanks to all the ophthalmologists and colleagues who joined us this evening. Your participation is what that gives us every Acquio's academic initiative a wonderful thrill and ecstasy. Thank you. Thank you, Rahul. Over to Rahul.
Thank you, sir. Good night, everyone.
Good night.
Good night.
Good night.